My name is Liza Keating. I'm a consultant in emergency medicine and intensive care just down the road here. And I'm here because I'm the research lead for the emergency department. And it was 6 months ago I was in this same lecture theatre, and Peter Tyrer, who some of you may know, who's a psychiatrist at Imperial, came up to me at the end of the conference and said, would you give us a hand with this project? And I was like, really? But well, I'll tell you what's happened. So chest pain for us in the emergency department is really common. It's probably at least 5% of emergency department visits, and you may not be aware that our numbers have gone up and up and up. So that's probably between 15 to 20,000 patients just down the road coming in with chest pain. It makes up about 40% of emergency admissions, and for some patients there's a very clearly defined clinical pathway. If you are having an MI, we're audited on our times to get patients to the cath lab. They come down on us if we're too long, if we're too slow, and for some patients who have ECG changes and classical pain, it's quite relatively straightforward to pick up. But this audit was done looking at patients coming through a rapid access chest pain clinic where they looked at nearly 9,000 patients over 2.5 years. And so for those 599 patients with a primary endpoint of cardiac disease, either MI, a diagnosis of unstable angina, or a cardiac death, at least just under 1 in 3 of those actually had atypical chest pain, which wasn't classic. So for us, this is a high-risk presentation. We have to risk stratify the patients. They could be pneumonia, they could be PE. We have to go through a process of training our juniors to exclude serious pathology. Our College of Emergency Medicine has now asked us to undertake consultant sign-off for everybody with non-traumatic chest pain we're sending home. And what do? We send the patients home with advice. But actually, background to the COPIC study is that probably for 75% of these patients, they'd actually have a diagnosis of panic disorder, depression, or anxiety. And the process of a representation with chest pain, whether or not you have cardiac disease or not, is quite alarming and frightening for patients. And what we do in no way resolves their fears. So they go home with an advice sheet. If they're lucky, they get told that there's no active cardiac disease, and what we're doing is not really doing very much for this group of patients. So there was a systematic review done in 2005 and repeated in 2010 that said it was really only a modest to moderate benefit up to 3 months for cognitive behavioural therapy for this group of patients. And the COPIC study group have looked into this in a little bit of detail, and it's actually, there's a resistance of patients to hear that what they've got might be anxiety or depression, so they don't want to hear a psychological explanation for their condition, and the resistance from the people who deliver the therapy when it could actually be serious pathology, well, serious in terms of pathology that might kill them in the very short term, and there's an inability of the therapist to deliver treatment well to this group of patients. So the COPIC study is a randomized control trial of a modified type of CBT for non-cardiac chest pain. So there's 2 major research questions in the study: whether an adapted form of CBT for non-cardiac chest pain, 2 to 6 sessions, leads to reduced anxiety. And there's also a second arm to the study where we're going to look at where they're looking at health service costs. So we're trying to get 120 patients in, so they have to have been to the emergency department or to cardiology once, and they will get recruited on their second presentation. And the standard treatment is quite variable, so if I see a patient, I may just get them to go back home to the GP, follow up with the GP, or they may get sent to rapid access chest pain clinic depending upon what's going on, other things. So the standard arm will be variable, but the experimental arm is 2 to 6 sessions, and 10 components to the intervention that's being delivered. They can get up to 3 booster sessions, and the difference with the COPIC study is that it's being delivered by nurses or people with a medical background trained in cognitive behavioural therapy, and these are going to be monitored by the original people behind the original study to see if it's sufficiently well delivered and true to the original technique. So the outcome is going to be the treatment group are going to get a whole battery of anxiety inventories, from self-reported of chest pain to generalised anxiety and depression score, social functioning, and a quality of life score, where the standard care are just going to get the anxiety inventory. And to get into the study, you have to have been in twice, and you could have actually had cardiac disease in the past, but the presentation you've come in with this time is non-cardiac. They obviously have to be able to consent, and they have to be adults under the age of 75. And people who are under psychological therapy already are being excluded, or just started on a new drug. So intention to treat analysis is going to be taken, and the power calculation is on a 4-point score. A difference between the two arms and the health anxiety inventory is thought to be seen as significant. Sensitivity analysis will be done at 6 months and at 12 months using a random effects regression model, and there's also going to be an economic analysis to see if it's cheaper. Any questions? Is it questions at the end?
I think we've got a minute or two,
okay.
Actually, so we could bend the rules this time.
Why are you only measuring health anxiety in
Because I'm not sure 100% of the answer to that, but you mean as opposed to all the other, because I imagine that...
All the others are interesting outcome measures, but if you can't draw any inferences unless you get control groups.
I think that they're only measuring, I'm actually just doing the recruitment, but I think they're only measuring, looking at anxiety scores, and they're looking at hospital attendances to allow an economic analysis to be done as well.
It's also,
Sorry, thank you, hi.
It's also based on the CHAMP study that Peter Tyler did a few years ago in some of the London hospitals, and they found that they were looking at health anxiety with patients presenting to lots of different areas of the hospital, and they found that non-cardiac chest pain was one of the biggest areas of health anxiety, which is why they're possibly using that measure. But without Peter here, I couldn't tell you for that.
Yeah.
Okay.